Okay, so this lecture is going to be on emergency contraception. This is Katrina. So let's just start with an overview of where we're at with emergency contraception in the U.S. So 10% of women in the U.S. have used it at some point in their lives. It can prevent pregnancy up to 5 days after unprotected sex based on whichever method you're using. So in general, the sooner you take it, the more likely it will be effective. It can be expensive. The morning after pill is around $50 over the counter at the pharmacy. And about 21 states in the U.S. have some kind of a statute related to emergency contraception, Minnesota included, and then 16 have a legislation around requiring hospitals and or clinics to provide information or even access to emergency contraception for women who have been sexually assaulted, and Minnesota is one of them. There's a specific 2 emergency rooms offering it in the event of sexual assault. So options are basically 3 options. So the Paragard is an option, and then for hormonal contraception, there's 2 ways. One would be one of the classic morning after pill setups, which there's 2 in the U.S., and then the other one is the USB method, is basically taking a birth control concoction based on whatever birth control you have at home, which I will explain in a minute. So first of all, with the Paragard, that's really 99.9% effective. So implantation takes a little bit of time after sex. The Paragard can be put in up to 5 days after unprotected sex. So there's a little bit of a time window there. And then we know that it is spermicidal, right? So as soon as it's put in, it's confusing sperm. They don't know where to go. And it is decapitating sperm, and then it's also creating a hostile environment within the uterus, making it tricky for implantation. So the sooner it gets in, the more its mechanism of action would be preventing sperm from ever finding the egg. And then for hormonal emergency contraception, that'll reduce the pregnancy risk from being about 8%, so any given time that people have sex, somewhere around 8%, down to 1.2%. So that's a 75 to 90% reduction in pregnancy risk. It's pretty significant. So again, the FDA has approved 2 options in the U.S. for what we call the morning after pill. One is Plan B, and then the other is Ella. Plan B can be found over the counter, whereas Ella is still prescription. And then the USB method. So first, let's just look at the WHO eligibility criteria. So for hormonal methods, as long as they wouldn't otherwise have any restrictions for being on combined oral contraceptives, then it would be perfectly appropriate for them to qualify and to be appropriate for taking hormonal contraceptives. And then for the Paragard, it would basically be the same. I mean, it is the same as if we weren't in an emergency contraceptive situation. However, you need to also keep in mind that they might have increased risk factors for some of the things that you would consider before putting in an IUD. The main one being if it was around rape or assault that had led to the situation of needing emergency contraception, they may be at a higher risk for already having a sexually transmitted infection. We wouldn't want to put in an IUD if we thought we had a known infection there. So that would be something to consider. So what would the mechanism of action be for hormonal forms of emergency contraception? Well, that's really going to depend on where she is in her menstrual cycle. So if she's still more in the first half of her cycle, then it's going to prevent FSH from finishing up maturing that egg within the follicle, right? So it's basically like it's a big surge of birth control. It's like high-dose birth control. That's what this is. I suppose I could have gone through that piece first, but that piece is coming. So everything that we think about normal hormonal birth control doing, that's what this is doing, but in kind of like a bolus sense, rather than being that ongoing, consistent estrogen and progesterone every day. So It can prevent FSH. If mom was about to have an LH surge and ovulate, then it could blunt that LH surge or prevent the LH surge. So it's sending a bunch of estrogen and progesterone to the brain saying don't release LH, right? It would also be thickening up cervical mucus to prevent sperm from being able to get to the egg. So maybe by the time she takes it, some of the sperm has gotten past, but not all of the sperm has gotten through the cervix. So that's where you think about timing of taking it can have a big impact on how effective it is, right? So we have about 72 hours is the time frame you're thinking. And then slow to fallopian tube motility, so it's not as easy for the egg to climb down or the sperm to climb up. So that could also prevent it. And then thinning that uterine lining to prevent implantation. Again, based on where she's at in her cycle, any of those things could be the mechanism of action, and probably more than likely it would be a couple, three of those things combined. So the primary side effect is nausea, vomiting. You think about normal hormonal contraceptives, that can be one of the biggest side effects that you'll hear women talk about. And in this case, they could take 4 to 5 pills even with the ESB method, where it's kind of a concoction. So about half of them tend to be nauseous, whereas about 19% end up throwing up. And if they do throw up, we want to think about, is the emergency contraception we just took effective? So if it's within 2 hours, then you might want to think about repeating that dose. Otherwise, by 2 hours, we're going to assume that we've absorbed enough of it for it to be effective. The Plan B pill and Ella, the 2 other morning after pills that are FDA approved for this, they're around 20% of women are nauseous and maybe 5% throw up. So it's linked more with estrogen. Both the morning after pills are just progesterone. And then as far as adverse effects go, they're unlikely. Since it's just such a short duration, it's 1, maybe 2 doses, you don't have to worry about very much on that front. However, one concern that's been brought up is, well, let's say it doesn't work. Could this cause problems for the fetus, or would we be more likely to have an ectopic pregnancy because we were slowing the tubes down? And basically, we haven't found any evidence for either of those things. And as far as the ectopic risk goes, because pregnancy period is such a decreased risk, that ectopic risk is not as much of a concern, just because we're so much less likely to end up pregnant in the first place. So I think with all of this discussion, really reflecting on when you feel like life begins, I think is really appropriate to be processing. So I think within Christian circles, the ones you hear most often would be fertilization or implantation. Thinking about, when the sperm meets the egg, that being the moment, and then others saying, well, when the egg implants and actually has access to ongoing growth, because independently the egg wouldn't be able to make it, that maybe that's the point where life begins. You'll hear other people say it's when the heart starts beating, or when mom can really feel baby, or maybe we say it's viability, or not until the birth. So definitely there's a widespread for people's comfortability, I know, with options counseling, which we're not talking about in this situation, but even just asking a woman who already is pregnant, when do you think life begins? If you have her put an X on a spectrum of a line that starts with fertilization to birth, the closer her X is towards the beginning of the pregnancy process, the harder it can be for her down the road to think about struggling with issues of guilt or that kind of thing around abortion. But in this case, I think I'm going to let most of you do your own processing individually, but with fertilization versus implantation, just knowing that the medical community would define pregnancy as starting at implantation. So based on that definition, emergency contraceptive would not be considered abortive, because if the egg has implanted, emergency contraception will do nothing to change that. But even when you think about the mechanism of action for emergency contraception versus your typical COCs, they're basically working in all the same ways, except that with emergency contraception is a little bit more of a potential for ovulation to have occurred, whereas with COCs you're a lot more likely to have been able to prevent ovulation in the first place. But all of those pieces, that preventing the FSH, preventing the LH, thickening cervical mucus, slowing fallopian tubes, that's something that normal COCs would do as well. And I tell women who come into my office, if they feel like, I don't want to wonder at all if anything I did might have prevented a fertilized egg from implanting, that I would have absolutely no part in that, then we steer sorry, so then I say we're going to just steer clear of all hormonal methods, whether that's the IUDs or whether that's oral hormonal methods, whereas a lot of women feel comfortable with combined oral contraceptives simply because the main way they're working is preventing ovulation, even though there's still a small chance that if the sperm did meet the egg, it would still be trickier for that egg to implant. And I don't know that it's necessarily helpful within the mix of this discussion, but realizing that 3/4 of fertilized eggs are naturally going to come out without ever implanting anyway. So, ultimately what we're doing is making sure that women are understanding, to the best of our knowledge and to the best of science's knowledge, what the effects that we're putting into our body are having, or I said that kind of funny, how the medications we're taking are impacting our body and impacting our cycles, and then from there asking for wisdom. So I hope that kind of helps to give at least a little bit of an overview and start to have some wheels turning. We don't have a specific forum for this, but I think if any of you would like to just explore the concepts around this, whether it's birth control in general or specifically around emergency contraception, I would be happy to dialogue with you about this further, whether that's one-on-one or if I get enough interest, perhaps we could even do a Google Hangout and talk about it too. But I do think this is an area, we deal with it so much day to day. It's an area that as much as you can flesh it out for yourself, how you feel about it and where you're at, and maybe what you feel comfortable with for yourself and your own body versus what you feel comfortable with as a provider, in being an avenue for women being able to make their own choices. Wherever your comfort level is, I think it's worth dedicating a little bit of time to step back and process that, whatever that looks like for you. And again, I would be happy to join you in that process. So to get into specifics just a little bit more, I wanted to tell you the story of the morning after pill in the US. So we generically call it the morning after pill, but there's 2 that are FDA approved. So the first one is Plan B. Both of these are progestin-only methods. Plan B you can take within 72 hours of unprotected intercourse. However, some sources have thought that it might possibly be good up to 5 days. Definitely sooner the better, and efficacy is associated, is very linked with time that way. So there's a 1-step and a 2-step method. Basically, in total, you're getting 1.5 milligrams of levonorgestrel. So that could either be 2 doses of 0.75 or 1 dose of the 1.5. So in 1999, it was made available by prescription only. And then in 2006, it became available over the counter for women 18 and up. And then it was still available for women younger than that, but only by prescription. And then in 2009, it became available over the counter if you were 17 or up. And then less than 17 became prescription. And then between 2009 and 2011, you can see that Ella came on the scene. But we'll stick with Plan B and flesh that story out first. So then in 2011, interestingly enough, the FDA approved Plan B as over-the-counter for women of all ages. However, FDA is not the only step in that process. So the Secretary of the Department of Health and Human Services disagreed with that decision by the FDA, and so it wasn't able to be launched as being available over the counter for all women. So that's where we're currently at, and it really is a bit of a drama scene. This is definitely a hot topic in politics in general right now, reproductive rights for women. So then Ella became an option. Ella is a different form of progestin. Everything else in the Plan B world is levonorgestrel, as you'll see in the next slide. But Ella is a little bit different. It's marketed here, and then in Europe it's called Ella-1, and then a different form of the same progestin is used for fibroids. But that's the only place I've ever seen this form of a progestin, is in these forms. It's just one dose, and then you can take it within 5 days of unprotected intercourse, and then since 2010 it's been available. Ella's only available by prescription. So those are the two that FDA has approved. And then, while perhaps not formally FDA approved, this is a very widespread and generally respectable way to approach emergency contraception. So the way the SB regimen works is it's nice if she's already taking COCs at home. So maybe she calls you and she says, I just realized I skipped 3 days and it was okay because we were using condoms, and I realized the condom broke. Then you say, okay, let's see what COC you're already taking at home. And basically what you're doing is this last little bit here. You're figuring out how can we get her 200 milligrams of estrogen to 1 milligram of progestin. And that's levonorgestrel to be specific. So it's all our birth controls are the ethinyl estradiol, and then the levonorgestrel is the type of progestin we're going to use. So what you do is you figure out how many pills it's going to take to do 200 to 1 milligram, and then you divide that in half. And she takes one dose when you're talking to her, and then she takes the next dose 12 hours later. So there's a bunch of charts to figure out how this would work. And then you'll notice if you compare the dosing to like Plan B that's also levonorgestrel, this is a little bit less progesterone, but then now we've added an estrogen, whereas the other Plan B pills were just progesterone only. So I'm just gonna, you can see one of these charts to see how it would work here. I'm just gonna take us to this website so you can see how this works. As you scroll down, you're looking for whichever one she has. Oh, she has Lovril. Great. Okay, so this looks like 4 white pills for dose 1, 4 white pills for dose 2, and then that gets us where we need to be. Let's just scroll up to see what our reference was here. What are these columns meaning? Okay, yep, first dose, second dose, and then this is how much estrogen we're getting and how much progesterone we're getting. So in this case, it's a little bit less than that 200 to, oh, is this per dose? Yeah, this is per dose. Okay, sorry. Okay, so we said we were going to do low overall. So we have dose 1, dose 2, so we had 120 and 0.6. So then we were shooting for roughly 200 to 1 as our total, and we ended up with 240 and 1.2. So that's how it would work. So these charts are pretty readily available, and again, you have one in your textbook as well. Alright, so I think that is it for this week. Feel free to email me with questions as always, and happy studying. This is really important information to feel like you have at least a good enough handle that you're ready to start the conversation on the phone, because this is the one that doesn't come up in such a manner that you have plenty of time to research it before chatting with her. This is your this is your page at 5 a.m. in the morning, and you don't even know how these people get the pager number, but they do get the pager number, and they're panicked, and you want to roughly have an idea of how to present it to them in such a way that you can make a plan. All right, so have a good week. Bye.